Hi, my name is Dr. Daniel Petrylak. I'm professor of medicine and urology at the Spinal Cancer Center, which is part of Yale University School of Medicine and is in New Haven, Connecticut. And my topic today is novel targeted treatment and its integration with precision diagnostics. As you know, the field of prostate cancer is becoming more and more complex in terms of sequencing agents. In the past, classically, we had given agents for hormone-resistant disease. We did not add anything to androgen deprivation therapy to the hormone-sensitive state, but now drugs such as abiraterone, docetaxel, enzalutamide, the combination of darolutamide and docetaxel, and the combination of abiraterone and docetaxel are being used up front. And then some of these agents are then being again used in the castration-resistant state. And the question is, will they still retain their activity, or will these be resistant to the treatment? And we don't know the answers to that. So sequencing is going to be an important question in the future. Akin to those lines, when we're looking at other hormonal agents in castrate-resistant prostate cancer, we know that agents such as enzalutamide or abiraterone after enzalutamide or vice versa really don't have great response rates. In fact, the median duration of these responses is fairly short, anywhere between 3 to 5 months, and the PSA decline rates are very, very variable. And this may be related to the duration of response to the patient's prior next-generation anti-androgen. So we need newer treatments for the treatment of castration-resistant disease, as we know that the hormonal axis is still intact. So one way that we've approached this at Yale is to look at PROTACs. What are PROTACs? PROTACs are agents that basically destroy proteins. The PROTAC will bind to a specific protein, and it will basically serve as a marker for the E3 ligase ubiquitin pathway to chew up the protein via the proteasome. So it's a way of marking a protein and using your own degradation system to degrade that protein. ARV-110 is a PROTAC that was designed to attack the wild-type androgen receptor, as well as other clinically relevant mutants. And one molecule of ARV-110 can basically take out as many as 400 copies of the androgen. So a phase 1 trial of this drug was performed at Yale University, as well as other sites across the country. And this was performed in men with prior treatment with abiraterone and enzalutamide. They had to have at least 2 prior therapies. And we found that there was an exposure-activity relationship in heavily pretreated patients in the phase 1 study. But interestingly, in those patients who had the T878X or H87Y mutation of the androgen receptor, it was found that the PSA decline rate was 40%. And for a recommended phase 2 dose, we selected 420 milligrams daily based upon safety, pharmacokinetics, and efficacy. So the phase 2 study looked at this group of several groups of patients. These are patients with confirmed metastatic castration-resistant prostate cancer that have disease progression by either 2 rising PSAs or by radiographic criteria. There were 2 different biomarker-defined subgroups. These are patients with 1 to 2 prior novel hormonal agents, less than 1 prior chemotherapy regimen. And then we looked at this in terms of androgen receptor mutation, the 878X or the H875Y mutation, wild-type androgen receptor, or the L702H or the ARV7. And we looked at both less pretreated or heavily pretreated patients. So we gave 420 milligrams of ARV-110, which was an oral agent, and dose reductions were permitted, as well as interruptions for adverse events. And the primary endpoints were PSA response rate, as well as RECIST response, then duration of response, overall survival, and PK were also analyzed. And this is the data analysis as of December 21st, 2020. These are the baseline characteristics in the phase 1 group. This is the combination of the phase 1 and phase 2 trials. We had a median age of 70 to 74. About 38 to 44% had visceral disease, and about 3/4 of the patients in the phase 1 group had prior chemotherapy, and then 31% in the phase 2 group. So if we look at those patients who harbored the 878 H875 mutations, we see that the PSA the decline rate of 50% was 46% overall, and 30% of patients, the PSA decline rate of 30% was 57%. This was 28 patients of that population that were positive. This is about 10% of the overall population. 2 of 7 patients with this mutation had resist responses that were confirmed, and these were partial responses. And 43% of these patients with the 878 or 875 mutation had a continued on treatment for at least 24. PSA declines were seen all across all subgroups of patients in this particular trial. So not only the 878X or the H875Y mutations demonstrated significant PSA responses, but wild type was somewhat a lower rate, 11% of the 50% PSA decline, 20%, 30%. The 72H ARV7 group had a lower PSA decline rate, 4% versus 20% for the 30% PSA decline rate, and the less pretreatment had a slightly better PSA decline rate than the wild type or the 72H, 22%. The ARV7 variant is not surprising because ARV110 was not designed to affect that particular splice variant of the androgen receptor. There are other ways of targeting the androgen receptor and ligand binding pathway or domain of the androgen receptor. And this is ODM-208, which is a oral compound that shuts down all steroid synthesis. And in patients who have a ligand binding domain mutation, the PSA decline rate of 50% is 68%. And in all patients, it's 32%. So again, there seems to be a selection factor in favor of the ligand binding domains. And the ligand binding, those that don't have the mutation, it's an 8% response rate. And this slide just simply summarizes that we have really complete abrogation of all steroids, including dihydroxy and epiandrosterone, androstenedione, and 11-hydroxyandrostenedione, as well as 11-ketotestosterone. So in conclusion, the ligand binding domain of the androgen receptor is a potential target for the treatment of castrate-resistant prostate cancer. Phase 2 and 3 trials are being designed to evaluate these compounds in castration-resistant disease. Thank you for your attention.